And I think we can start. Uh, So, you were with us yesterday on RESP, but as Savimbia said, we are now here on endocrinology. And, it's a bit of a wide topic, so we'll try to divide them into separate days so that it can be easier for you guys to understand. Because there are so many organs here that you need to assess as well, not just not just the lungs as of yesterday, but also there's the thyroid, uh, and there's the foot, there's a whole body aspect to this. So let's start. So, introduction to endocrine history. So these are the conditions that one should expect in the endocrine ward. The endocrine ward, for those who are there, first of all, if I may ask, is there anyone rotating in GF? You guys hear that? Can just move to place. You guys, is there anyone among you rotating in endocrine right now? Hello? Are there people amongst us who have been to the endocrine ward before? It's in ground floor, GFD. Hello? I hope I'm not breaking. Okay. Well, I'll just move on. So these are conditions that one should expect in the endocrine ward. You'd see diabetes mellitus, along with complications. Now, you won't just see diabetes, you also see complications. The most common being the diabetes. When you enter the endocrine ward, you'll find some people who are wrapped in bandages around either their left foot or right foot, some with only one foot because the other foot has been amputated. Man, some other cases you'll find someone who's a bit groggy in the ward. They tell you they have diabetes, but they appear groggy, confused, almost sleepy, about to enter a coma. That's the DKA and the HHS, which I'm sure you've covered in some aspect in your clinical chemistry. And you'll also find hyperthyroidism there. Hypo, not so much, but it's still there. Hyperthyroidism is where you'll find it's a bit more common. There's okay. During our end of year, there was one patient who had a metabolic disturbance that's alluded to parathyroid gland dysfunction. Still rare. That's extremely rare. Like in the ward, that's extremely rare. So we expect to find a parathyroid with an impaired parathyroid gland or anything. Just diabetes and stuff to do with the thyroid. That's what you should see, sana sana. Okay, so moving on. How to take an endo history. Just like yesterday, you'd see that there's the biodata, the presenting complaint, the history of presenting, all HPI. There's the past medical history, OBS-GYN if your patient is a female, and then family social, review of systems, there's a summary, general examination, and systemic. So I will take you through biodata all the way to summary, just like history, and Savimbi will take you through general and systemic. Okay, so on biodata, this one, you need to remember that now you're in a different ward. So biodata, okay, particularly in diabetes, in thyroid, in stuff to do with thyroid, it's a bit relaxed. Can talk about name, age, gender, residence, occupation, then how they present, and then how they the date of admission, and then now you can just leave it at that with a few more details in the thyroid. But then in diabetes. Now, the diabetes patient is a bit more. You have to explain, still in biodata. Yeah. Okay. Mhm. At what point did I lose you guys? Hello? Hello, guys. I think one of you should unmute and tell me if I
Hello.
lost. Hi. At what
Hi.
point did I lose you guys?
Okay, it's not like entirely, but like your voice keeps fading away. Then
Okay. Um, is it better now?
yeah.
Okay. Sorry. Dealing with KPLC. Wamefanya ile kitu. So I'll just take you back. Just take you back here. So we're dealing with how to take an endocrine history. Yeah. So your parts of the parts of a history will be biodata, presenting complaint, history of presenting complaint. There'll be a past medical history, an obs-gyn history if you're female. There's a family social history, review of systems, and a summary. That's on the theory part. Then on the clinical aspect, we'll have the general exam and the systemic exam. And the conditions that you're most likely to face in an endocrine ward would be diabetes. Diabetes mellitus, most common. And then you'd have complications like the diabetic foot, where you'll normally see these patients with a foot wrapped. Yeah, their foot will be wrapped in bandages. And they'd also have this. There are some who will have an amputated foot. That's also a complication. And there are some who you'd find appear groggy. Yes, they have both feet, they have everything, but then they're just groggy, confused, almost in a coma. That's where this comes in, EKA and HHS. Those are some complications that you face in the endocrine ward, just on diabetes itself. Then we come to the thyroid. Now, on the thyroid, you'll either have a hyperthyroidism or a hypothyroidism. Now, on hyper, that's a bit more common than hypo because hyper is, and for what reason, but hyper is more common in the endocrine ward. You'll find like five patients with a thyroid issue, and most of those five will have a hyperthyroidism as opposed to hypo. But then there are also some conditions that are unique. You'll find someone with a metabolic disturbance that is akin to a parathyroidism issue. Take note that that's really especially rare. Like there's only one patient in, let's say, 3 months who will come presenting with a parathyroid complaint. And unfortunately for us, that guy came in when we were doing our end of year, so tough on us. There's someone who had to decipher that when they're expecting either a thyroid or diabetes. So, that's on them. Hopefully I think they did well. They did well with that. So these are the common ones that you'd expect: diabetes, hyperthyroidism, and it's hypothyroidism. From there, they're all really unique. Okay, so I've gone through this, and now we start with biodata. Now, in your biodata, usually you have your name, age, gender, residence, occupation, uh, how, and any chronic illness that they are living with, and such. Yeah, those are the important information. But now, in diabetes, it's a bit more complex. I will show you in a while. Because in diabetes, the lecturers want to know everything, like how they were diagnosed, how long ago, how it happened, what was the management given at that time, how has the diabetes been controlled, is the patient adherent to medication, how is their diet, are they compliant with their diet? That's something. Alafu, their last known blood sugar, like Now that you're talking about them, now that they've come to you presenting with this, what is their last known blood sugar so that we know that truly they have been okay with their drugs, their diets? So, I'll give you an example. So we have PK, a 49-year-old male from Kangemi who is a carpenter. I've shortened this so that I can give you more of I've shortened the usual stuff so that I can give you more of what is expected, the extra details. So, 49-year-old male from Kangemi who is a carpenter, date of admission 7 days ago. Okay. He's a patient living with diabetes mellitus. You don't say he's a diabetic patient or a known diabetic patient. Some lecturers would condone that. Others, particularly in the endocrine ward themselves, like you'll find someone called Dr. Ilovi, they would perhaps insist on letting you know that they are living with diabetes mellitus, living with tuberculosis, living with some chronic illness of some sort, living with diabetes mellitus for the last 16 years. He was diagnosed at KNH 16 years ago when he came in presenting with an increase in urine frequency and an increased sense of thirst for 2 months. Take note where the patient was diagnosed, how long ago, how it happened. I hope you're taking note of that. Then he was placed on insulin and since then given Mixtard, which he is still currently on. This is a short-acting and intermediate-acting form of insulin. Okay, so you've gone from how they presented those 16 years ago, where he was diagnosed, how he came in, what he's been given, and what he's still on. But then you also need to talk about whether or not they're actually compliant with this. So, okay, compliant is a lab word, whether they are adherent to it. So, but reports non-adherence to medication and clinical follow-up due to financial constraints. He also reports notable dietary non-compliance. He often consumes high carbohydrate and high sugar foods with irregular meal patterns and frequent eating out, leading to poor glycemic control. He also drinks beverages with added sugars instead of focusing on hydration, presenting a challenge in controlling his blood glucose levels. This is just biodata. This is still biodata. In diabetes, mention how they were diagnosed and what has happened since then. That's in biodata. In any other condition, it's fine to just say, it's just fine to say that he has been living with this for the last 16 years and he's placed on this, and he's, but reports non-adherence. Yeah. And you should also have a 24-hour recall. On the diet part, you should also have a 24-hour dietary recall. When you're saying, when you're talking about your last known blood sugar, also take note to include what has the patient been eating 24 hours before you're taking your history. As in, if it's in the morning, ask him, na ulikula nini usiku, ulikula nini mchana, ulikula nini asubuhi jana. For diabetes, it's very important to ask them that. Okay. Now, on to presenting complaints. The ones that I've highlighted there. Okay, so I'm being asked to repeat the difference between compliance and adherence. Okay, so compliance is a testable, okay, I would say think of it as a subjective and objective. Subjective is adherence because that's what the patient is telling you. This is what the patient is telling you and what you can just believe. You can choose to believe it or not because it's subjective. The patient is the one telling you that I'm the one taking the drugs, and that's all I know. I'm taking the drugs. Kwani utafanya nini? Now, compliance, on the other hand, is objective because that one's more with the labs. The labs are the ones that the lab tests, like let's say RBS, for taking into context that we're dealing with a diabetes patient. Uh, RBS or fasting blood glucose. Those ones, if they are high, they will tell you that this patient has not been taking medicine like that much. So that would be compliance. But then adherence is something that the patient is telling you like, mi huwa nachukua dawa, lakini kuna siku zingine siwezi juu ya pesa. Now that's adherence. That's the patient telling you. So it's very subjective, whereas compliance is lab-based, investigation-based. That's very objective. I hope you got that. So on to presenting complaints then. The ones I've highlighted in red are the ones that are, okay, also weight loss and weight gain. Those ones, I should have placed them in red. So those ones, sana, are the ones that the patient comes complaining to you about. So in diabetes, you'd definitely have thirst and increased urine frequency, what we call polydipsia for thirst and polyuria for the increased urine frequency. Those are very, very important in diabetes. In any diabetic patient, they will more or less, some more often than not, tell you that, oh yeah, nilikuwa nasikia hivi. I wanted to drink water and I wanted to go take a short call. More than usual. Okay. And then you have weight loss, which is in hyperthyroidism, unintentional weight loss with increased appetite. That will point you straight to hyperthyroidism. Same for weight gain. Same for weight gain. There would be a primary hyperthyroidism, yeah? Just a bit. Okay, sorry. Some other technical issues have arisen, but since sorted. Weight gain, primary hypothyroidism. Then you come to muscle weakness. Muscle weakness, there's the painless as well as painful. Now, the painful ones are vitamin D deficiency and whatnot. Whereas the painless ones are the ones like Cushing syndrome and thyrotoxicosis. Okay, so now on cold intolerance. Does anyone know what cold intolerance is? I'm leaving it open to anyone here. Like, if you can tell me what cold intolerance is. Okay. Hmm. So I'll just say, okay, cold intolerance is an absurd amount of feeling cold that you don't, it's not normal to people. Same for heat intolerance. I mean, the body is very hot. You don't know what's happening. You're like, hey, why am I hotter than usual? By hotter, I mean temperature, not how you look. Something like that. As in, so cold intolerance would mainly point you to hypothyroidism, whereas a heat intolerance would point you to hyperthyroidism. And then increased sweating. Like someone with hyperthyroidism would of course be sweaty. And also, okay, now the thing is to differentiate between there's some tricky situations here. Endocrine conditions share something with anxiety. Sana, the thyroid issues typically have features that would also be found in anxiety. It's very important to know. Even Hutchinson says that, as in, the tremors, like the tremor here that would be rapid fine tremor in thyrotoxicosis would be a coarse uneven tremor in anxiety. Palpitations, thyrotoxicosis, also found in anxiety, but they're more, this one, thyrotoxicosis. That's why in anxiety, you also have to, this one will be taught in psychiatry later on, but it's also important in anxiety disorders to test your thyroid because they have some link in how they present. Okay, postural unsteadiness or postural hypotension. Leading, this will point you to adrenal insufficiency or long-standing diabetes. Visual disturbances um, also can be found in long-standing diabetes, uncontrolled diabetes. Why? Because there's something called diabetic retinopathy, which is a long-term complication, a microvascular complication of diabetes. Okay. Fasting symptoms like tachycardia, sweating, tremors, indicative of hypoglycemia can be found in a diabetic patient. Cramps and pins and needles, hypoparathyroidism. You can go read on how the parathyroid gland and calcium work, because that's actually why it happens, because of the calcium levels in the body. Neck pain and swelling, thyroid dysphagia, thyroid enlargement to the retro blocking the esophagus. And there are also some things related to the genitourinary tract. There's impotence, gynecomastia, excessive hair growth, amenorrhea, galactorrhea, androgens. Bowel changes, diabetic gastroparesis, skin changes as well. Okay, now let's move on. HPI, just as we said yesterday, is just gonna highlight the operates for each presenting complaint. Do an operate. Socrates for pain. Okay, so you do your onset, progression of symptoms, exacerbating factors, relieving factors, associated factors, timing, previous episode, severity of current episode. Then you go to Socrates for pain. If your patient has pain, then you do Socrates. Site, onset, character, radiation, associated factors, timing of pain, exacerbating or relieving factors, then you have severity of pain. Now, there's a slight catch in diabetes, in that when you're doing a diabetic history, you also have to query its complications, both macro and microvascular, before heading into risk factors and cause progression. You will be shown that in a short while. Like, diabetes is a multi-systemic disease. That's why it will have something in each system that you also have to rule out in your HPI. It's not just talking about how this patient has thirst and increased urine frequency. You also have to talk about what else can happen. How are they? How are they like in their CVS? How are they like in their CNS? How are they like in their RESP? How are they like in their every system can be affected by diabetes. That's why it's very tricky to sort out. Okay, past medical history. You ask about past admissions, surgeries, blood transfusions, any food or drug allergies, past medications, chronic illnesses like cancer, RVD status, and you also don't forget to ask about thread. Okay, thread, very important. Family and social history. Once again, be as human as you can here. A doctor should also be a humanistic person, not just a logical being. You're not a robot. Forget about that. I'm only here to take your history. At least make your patient feel like as if you're listening to them. So in endocrine, it is imperative that you ask about family history of endocrine diseases. Diabetes type 2 especially, because that one has a 30% chance, I think. 30, yeah, it's 3 times higher likely to occur in your family tree than type 1. Type 1 has like 5 to 10% of patients. The other ones is like 30%. Type 2 has a 30% chance of reoccurring in your first degree relative. So that's why it's important to know your family history. And also, I hope you guys have gone through the genetics part of IMED. Like actually, this is by Dr. Ilovi. I hope she's taught you how to draw a pedigree because a pedigree is very important in an endocrine history. So you're going to highlight three generations. You could start with the grandparents of the patient, then you go to parents of the patient, then you go to the patient themselves. That generation, then you can stop there. But sana sana, patients do not know what's going on with their grandparents, or their grandparents died before they could even know them. So if your patient has children, you can do parents of the patient generation, and then children, the children being the third generation. Okay. And this goes for whether or not the family members have the disease or not. Like just that you did a pedigree or asked with the family history. And this goes to any disease with a genetic predisposition, like hypertension. Hypertension also has something to do with genetics. Like if your dad and your mom have hypertension, yeah, I mean, you should be prepared to get hypertension. Not that you will, but you should at least be prepared. Yeah. Also, so now remember to ask about social support from the family and how they're faring on with the illness as a family. What changes have arisen due to the admission and diagnosis? What effects does the disease have on the family as a whole? Just go all out here. When you're presenting your family social history, make make the console know that you cared about the patient, that you're asking important things like maybe he's a father and his foot is amputated. How does that affect his work? Like if he used to be a manual laborer, how will that impact him? Does he have to look for another job? Does he know when he's going to be released? Does he have plans for the future? What about his children? What are they going to do? I mean, who's now the breadwinner? How are they paying for the school fees? How are they paying for his admission? Hata kama ako na NHIF, how are they going to do it? Okay, NHIF is now becoming obsolete. Stupidly, stupidly. No. Okay, no government sentiments here. But NHIF cover, we're going to shift to SHA. Those covers, they can't really do much. But then, what if? How are they going to pay? Are they doing a harambe? Are they selling? How? That kind of thing. That's also important. Just like yesterday when you talked about family social, ask those questions. Okay. So, review of systems. We're going to look at CVS, GIT, genitourinary, CNS, musculoskeletal, dermatological. Now, for some of these, you'll have already asked in your HPI because some complications, if you're talking about diabetes especially, some complications of diabetes are in the CVS, like chest pain. Chest pain will occur because of coronary artery disease. Nausea, vomiting, diarrhea, what they will occur because of diabetic gastroparesis. GUT, already, urine frequency is high. Okay, fine. The color is, you'll ask about the color, you'll ask about the volume, you'll ask about the flank pain, dysuria, nocturia, and all that. Still in your HPI. Yeah. So that's why in multisystemic diseases like diabetes, you don't usually have a review of systems because what you're just doing is you're basically repeating yourself here. They were all, if they have complications in each system, then and you've placed them in your HPI, then you don't need to do a review of systems. But then you still have these diseases like the thyroid, which don't have as many extra thyroid complications as diabetes. So those ones you can go to your review of systems and ask. Okay. Summary. Here, I would urge you to remember to be as brief as possible. Highlight the important bits, that is your biodata, your PCs, the very critical positives and negatives in your HPI. And if you think it's important that the console knows, put it there. But restrict yourself to 2 statements because you don't want to redo your entire history again because hey, no, that's boring. There's some lecturers who and the summary is very important because now it gives you a short, it allows you to pinpoint the important parts of what you've told the consult. Like as in, there's some consultants who don't even want to listen to your history. They just want to ask you, okay, tell me your summary. Then we can work from there. So your summary is very important. Never forget to do a summary. Yeah. Okay. And I think from there, I can leave it to Savimbi. Thank you.
Okay, thanks, David. Could you just keep sharing?
Oh, okay, okay.
My connection isn't as stable. So
That's
there
fine.
might be moments taken out of the meeting. Okay, so I can see Grace Makioti, you've raised your hand. There's something you want to say?
I have a question for David. Okay, maybe it won't be possible now, but could you like give us an example of how to like phrase the family history, mentioning all those things that you've said we're supposed to mention?
Okay. Well, give me a moment. I think I'll do it after Savimbi has finished his part, but I'll phrase it. I'll make sure to phrase it for you.
Okay, then the last one, since you said in diabetes we don't have the review of systems, when you're presenting to the consultant, you just skip that part or you mention that you don't have it because you had already probed on them.
In such cases, the consultants already expect you not to have a review of systems because you'd basically be repeating yourself, and they don't, and most of them do not like repetitions. So you just say, when you're presenting, you can just say, okay, if you feel like you have to say it, you can just say, as for the review of systems, they were already covered in the complications of diabetes, in the complications of when I was querying for complications, and then you move on straight to summary.
Okay, thank you.
Okay.
Okay, guys. So for the general exam, as I mentioned yesterday, there's a mnemonic JACO here. The J for jaundice, A anemia, C clubbing, the C cholinergia, cyanosis, O edema, L lymphadenopathy, W wasting, and D for dehydration. So once you've done that, you now move on to just looking at
Okay, so let's wait for him to rejoin.
right, sorry about that. Phone's the Wi-Fi. So I mentioned, after doing this, you can move on to, just look at the patient, just take a quick glance at them and, note if they're anxious. This is an expected finding, in hypothyroidism. Um, or, like they might be a bit down. They might seem in a low mood. This is often the case with hypothyroidism. And as David mentioned before, in cases such as DKA, they might be a bit delirious, a bit confused, you know. So after that, now you can look at fat distribution. This is also a very telling sign. In cases such as what is it, Cushing's. which is something you might come across in the ward. You might notice fat distribution's a bit uneven. It's a lot more, central than it is peripheral. They have, I think you guys have seen that one illustration of a Cushing's patient. You also should inspect for swellings. Most swellings, you'd expect to find in the neck region, in the cases of hypothyroidism or hypothyroidism, the Graves or the Hashimoto's, or anything like that. You'd also inspect for wounds. Wounds you'd expect to find in diabetic patients. You'd also check for the skin, feel for the skin, feel if it's, clammy and cold. This is something you'd expect, in what is it, hypothyroidism. And you might expect warm hands, warmer than usual in hypothyroidism. You should also check for the facial complexion. I'm not sure, but I think it's was it Cushing's disease, where there's some sort of hypopigmentation in the face. David, can you correct me if I'm wrong?
Cushing's has a moon face.
Yeah, but which condition has hypopigmentation?
Hyper. Mm, apart from microscope.
Hypothyroidism.
Let me check. But yeah, could be
Okay,
that one.
okay. And then you'd also inspect the surroundings of the patient, like I said yesterday. Check to see if there are any connections, IV lines, oxygen. Check for any leftover food beside the bed. Check for any walking aids. This is very telling in diabetic foot. Um, Also check to see, the beddings, to see if there's any stains or anything like that. Okay, next page. So for the systemic exams, in the endocrinology ward, you'll mostly be doing thyroid and diabetic foot exams. And then the thing is with these endocrine conditions, they affect multiple systems, like David mentioned before. So do not overlook other systemic exams. These are a must. Actually, a good rule of thumb is, depending on the presenting issue, if someone tells you, say, they have difficulty in breathing, then do a RESP exam, even if you're not in the RESP ward, specific symptoms. If someone told you they have stomach pains, abdominal pains, even if they're not in the GIT ward, still do an abdominal exam, because there might be things that you might overlook that could be quite costly. So I can just give you guys a quick run through a thyroid exam. So of course you begin with wipe. This is a mnemonic for wash your hands, introduce yourself, ask for permission or informed consent. This entails explaining to the patient what you're about to do. You wouldn't be comfortable with someone, just doing things. Assuming you're in the patient's shoes, you wouldn't be comfortable with, your doctor just doing things without, seeking consent. And then E, expose the patient appropriately. So for the thyroid exam, I think neck up is good enough, or chest up. As long as it's exposed, it's good. So you begin with the general exam in the thyroid exam. Like these systemic exams also have a general exam that's unique to. So for the general exam and the thyroid exam, you'd start with the hands. Here you'd be inspecting skin color, inspecting, you'd be checking for temperature. Um, you'd also be checking for pigmentation. Um, Cases such as hypothyroidism, I think the hands will be erythematous, red. Cases such as hypothyroidism, you might find they're cold and clammy. And then you move on to the pulse, check for the pulses. So there's like 7 aspects of the pulse that you check for. These include um, compliance of the vessel wall. You also check for character. You also check for symmetry, and two others I've forgotten. And then you move up to the face and you inspect, the face in general. You look and look at the skin. If you find a sweaty person, this could be telling of hypothyroidism, heat intolerance. You also could come across a moon face. This is in cushions. Then you move on to the eyes. The eyes, more specifically, the more the telling of what is it? Graves' disease. Things like Graves' disease, they present with exophthalmos. Does anyone know what that is? Someone maybe describe what that is. Just to meet yourself and then uh then I'll just have to pick. Bet, Thomas, could you please tell us what exophthalmos is? Noor?
Yeah.
Okay. So someone beat you to it. It was Grace Makioto. She answered bulging out of the eyes in the chat. Thank you, Grace. Okay. So you move on to inspection now. This is closer inspection. You inspect the thyroid more closely. So the ideal position a patient should be in is seated right in front of you, so you can check for symmetry. So as they're seated, facing you, you can check for symmetry of the thyroid area, and then you can ask them to maybe swallow their saliva, or if they have a cup with a liquid inside, by the bedside, you could ask them to swallow, then inspect the movement, the throat, and then you could also ask them to protrude their tongue and also inspect for any movement in the thyroid area. So if you do get things like a thyroglossal cyst, this moves with the tongue. And then if it's a thyroid mass, it's stationary, it does not move. And then you move on to palpation of the thyroid area. So when you palpate, your ideal position should be from behind the patient. You palpate for any masses, any nodules. This could be very telling of malignancy. Uh, when you're palpating, you could also ask them to swallow or protrude their tongue and palpate for any movement. And then you also check the local lymph nodes, check for lymphadenopathy around the thyroid area. So swollen lymph nodes, this could also point to malignancy. To finish off palpation, you check for any tracheal deviation because you can just imagine if thyroid is swollen asymmetrically, then trachea will slightly be deviated. Goes without telling. Uh, Next up is percussion. So you percuss over the retrosternal region. So what you're percussing for is any thyroid swelling you may have missed. If the thyroid is swollen and the swelling manages to invade the retrosternal space, then you might pick up a dull sound. After that, you move on to auscultation of the thyroid. When you auscultate, assuming there's a mass, you might come across bruit. Does anyone know what a bruit is? Noor, maybe you can have this one.
I don't know this one.
Okay. Does anyone else want to try purity? What about Kasau Mark?
No.
Come again? Khalid?
You said Brui.
Yeah.
Oh, it's blood passing through an artery.
Yeah. So you're not too far off. It's blood passing through an artery, but then it's turbulent. So instead of like smooth, it's quite turbulent. So this is something, we'll come across when we go to the hospital. Okay. After that, now comes reflexes. You check for reflexes. In conditions such as hyperthyroidism, there's hyperreflexia. And in conditions such as hypothyroidism, there's hyporeflexia. Uh, does anyone know what hyporeflexia is? I'm sure you guys must have come across that while reading Hutchinson's. Angel, want to give
Um,
it a try?
yes, I want to try. I think hyperreflexia is when there are very quicker than normal responses to the like a stimuli, I'd say. Yeah.
Okay. You're not too far off. So hyperreflexia is basically an abnormal reaction to stimulus. Yeah. So, okay, picture this. You palpate for the tendon and then hit it with your patella hammer lightly, and then the muscle that supplies it has an exaggerated movement. That's hyperreflexia. Basically, it's an exaggerated movement, exaggerated reaction to a very small stimulus. It's not a matter of speed, really. You get me?
Yes, I do.
So hyperreflexia is the opposite. So this is less than normal reaction to force that's applied. So in hyporeflexia, you won't see the muscle move. So this again is something we'll try to elicit when we go to the hospital. Then you move on to pretibial myxedema. So tibial region, in cases such as Graves' disease, you'll find there's a lot of swelling. So there's pitting edema and then there's also myxedema. Pitting edema actually pits, like you could actually press on it and it will actually form depression. Well, myxedema doesn't form that depression. And then to finish off the thyroid exam, you inspect for muscle strength. So in conditions such as Graves, I think, you might come across myopathies, muscle weaknesses, or whatever. Okay. Now for the diabetic foot exam, here's a rundown. Again, wipe, W for wash your hands, I for introduce yourself, P permission, E expose the patient. So exposure basically expose both feet. Um, if you do find a patient who has a bandage wrapped around their foot, it's best to ask the nurses to help you open because some of the consultants actually they take offense if you don't, explore, so someone won't take, oh no, I found it wrapped as an answer. So after that, you can inspect for gait. So this would involve asking the patient to walk around if they can. Uh, you then inspect for footwear, whatever it is they wear, the type of shoes, um, whether they're closed, open, the material used, leather, or the other stuff, cotton, sure, or plastic, rubber. Yeah. After that, you now inspect the feet. So upon inspection, what you'll be checking for is hair distribution. In cases of diabetic feet, there's unusual hair distributions. There's usually less hair than normal. So, it'd actually be helpful if you ask the patient whether or not this is how it usually is, like whether they've had this hair distributed like this or it's recently changed. Another thing you'd inspect for is skin color. You'd also check for wounds. They're quite common in diabetic feet. You'd check for deformities. You'd also check for edema and calluses. So the thing is, with diabetic foot exam, you have to check everywhere. So that's from the knee downwards. You'll be also checking between the toes. You'll also be checking behind the foot, assuming the patient's on the bed, uh, that part, and underneath. You also have to check for that. Then you also have to compare. Although if you're lucky and get an amputee, then that's already the job's half done. So I don't think you have to do a diabetic foot exam. Just comment on when the dressing was last changed, and yeah, that's it. And then you move on to palpation. Now for the diabetic foot, what you're palpating for is temperature. You compare both of the feet, temperature in both feet. So you start from the knee, move your way downwards, compare the temperature. You also palpate for any pain or tenderness. And remember, before palpation of like any system, any systemic exam, before palpation, always ask if there's pain or tenderness before. And if there is, palpate that part last. And then you also palpate for the pulses. Now for the feet, pulses of interest include the dorsalis pedis. They also include the posterior tibial. And yeah, I think that's it. David, did I forget any?
Maybe the ankle brachial index, but that's not important for us at this level.
Okay, thanks. Okay, and then you move on to the monofilament test. So there's a monofilament. It looks like a needle, but it's not really a needle. It's just small like that. So this is to test for perception of pain or fine touch, make sure everything is intact, sensory aspects. And then with the monofilament test, areas of interest are the pressure points on the feet. So these include the toes, and then like that region, where a lot of pressure is applied. I'm sure you guys understand your own feet, so and just I'm assuming you guys have an idea of what I'm saying. And then you move on to the vibration test. Now, this is to conduct this, you need a tuning fork, specifically 128 hertz. So tune your fork, place it on an ankle joint, and then ask them if they feel the vibration, and then tell them to tell you when they stop feeling it. Ideally, this is done with the eyes closed. Then you move on to the proprioception test. Now, this involves, licking their toes up and down, up and down. It's best you orient them with the eyes open before you start. This is up and this is down. And then there's a certain technique to do this. That will do you when we get to the hospital. And then after you've oriented them, now you can ask them to close their eyes and then do it at random. So that's check for proprioception. So yeah, that concludes the diabetic foot exam. Is there another slide? Is this the last one? Okay. Next slide. Yes. So here we have a sample history of the diabetic sample history. So just like yesterday, I'll ask one of you guys to read the left half, and then another one reads the right half as we dissect it. So who would like to start?
I can start. Let me read. Oh, I mean,
thank you.
I start.
Yeah, just go ahead.
Okay. The patient, a 45-year-old male, has a significant past medical history of type 2 diabetes mellitus, diagnosed approximately 10 years ago at Gatundu level 4. This diagnosis was made through elevated fasting blood glucose levels and HbA1c. No patient, okay. He initially presented with symptoms of fatigue, increased thirst, and frequent urination, leading to his diabetes diagnosis. He is on regular follow-up at KNH with routine screening for diabetic complications. His diabetes was initially well controlled with metformin and lifestyle modifications, but over time his glycemic control worsened, leading to the addition of a bolus insulin regimen 5 years ago. Despite these adjustments, his blood glucose levels have remained poorly controlled.
Okay. So far what you've read, this captures the age of the patient, the sex of the patient, and their previous diagnosis of DM type 2. So this further on went to also capture how they were diagnosed. This is through FBS and HbA1c. So HbA1c and do you guys remember the other, what is it? The other gold standard diagnostic test for diabetes? It's two. There's HbA1c and there's another one. Someone like to attempt that?
Oral glucose tolerance test.
Thank you. Yeah, so HbA1c and OGTT. So this also captures how they presented initially with the symptoms of fatigue, excessive thirst, and frequent urination. And then it also captures that this person comes for routine clinics, also captures what medication they're taking, then also captures how this medication has affected them. So someone else, could you please read the other half?
Currently, he's on a bolus insulin regimen and takes metformin, though he admits to occasional non-compliance with his medication due to financial constraints. The patient checks his blood glucose levels twice daily, once in the morning and once before dinner. Despite his routine, his readings often exceed target ranges, with frequent fluctuations observed. He does not keep a consistent log of his glucose levels. He also exhibits notable dietary non-compliance. He often consumes high carbohydrate and high sugar foods with irregular meal patterns and frequent eating out, leading to poor glycemic control. Despite receiving dietary counseling, he has difficulty managing his carbohydrate intake and does not use tools for meal planning. He also drinks beverages with added sugars instead of focusing on hydration. His dietary habits, including irregular eating and high sugar intake, contribute to ongoing challenges in controlling his blood levels.
Thanks. Okay. So for the first paragraph, can someone tell us, okay, there's something wrong about the first paragraph. There's like a small statement that's wrong. Someone like point it out. Someone notice. Maybe you could point it out. Sadia? Hassan?
And I will say currently he's on bolus insulin regime and takes metformin. So maybe the exact amount of the metformin or the bolus insulin, which is it? Maybe I will say that. I don't know.
It's not that. So this is something that David stressed, and one of you even asked a question about the non-compliance. So this non-compliance, I think it should be non-adherence. Compliance is, lab, like this has to be a lab finding. Okay. And then one thing also that's missing here is what this person does job. So it's also key. It paints a picture of, like what this person's day-to-day looks like. Like, do they engage in physical activity? See, when this is an office person in the city, for the most part of their day, that's a sedentary lifestyle. Okay. David, next page, please. Okay. Someone else.
Okay, I'll read. The patient is stable up until 3 days ago when he presented to KNH with generalized body weakness, which he first noticed approximately 3 weeks ago. He describes it as a pervasive and significant reduction in muscle strength, resulting in diminished strength across all major muscle groups throughout the body. The onset of the weakness was gradual, beginning shortly after a particularly long work day. Over the past 3 weeks, the weakness has been persistent, with the patient describing it as constant, although it tends to worsen by the end of each day. The weakness is generalized, affecting the entire body, but is most pronounced in the arms and legs. The patient also reports a noticeable increase in both urination and thirst, which began approximately The patient also reports a noticeable increase in both urination and thirst, which began approximately 3 weeks ago. The onset of these symptoms was gradual, and they have become progressively more pronounced over this period. The patient describes urinating frequently throughout the day and often wakes up several times at night to use the bathroom. They have not measured the exact volume of urine, but note that the frequency has increased significantly. Alongside this, the patient experiences intense and persistent thirst, often feeling that drinking large amounts of fluid does not adequately quench it. This excessive thirst has led to a marked increase in daily fluid intake, primarily water. The patient has also noticed associated symptoms such as fatigue and has experienced unexplained weight loss and changes in appetite.
You can just finish up.
Pardon?
Please finish.
Oh,
And you
okay.
can read the other half.
He denies any numbness, tingling, loss of coordination, or visual changes. The patient reports no muscle pain, cramping, or signs of muscle wasting, weight changes, appetite issues, cold or heat intolerance, indications of metabolic or endocrine issues, no shortness of breath, chest pain, swelling, or palpitations, no easy bruising or frequent infections or bleeding for any site, no fever, chills, night sweats, no joint pain, skin rashes, or photosensitivity. The patient does not show evidence of nutritional deficiencies, psychological distress, chronic illness, or medication-related side effects.
Thank you. So here we have the presenting issue, which is body weakness. We also have the timeline, which started approximately 3 weeks ago. And then we also, dissected it, um, like the operates or the separates. Then what we also have is noticeable increase in urination and thirst. So there's also a comment that explains that this has led them to feel unquenched despite having taken large amounts of fluids. Then under associated symptoms, it's not associated. This right the part on the right half of your screen. This is like a review of systems. So this is in the HPI. It's not as comprehensive, but you get the idea. So by the end of your HPI, you shouldn't have any other system to like rule out. Another thing that may not be here is the complications of diabetes. That carries a lot of marks in HPI or diabetes. Actually, any condition, everyone wants to know, like, are there complications? Like, has the patient experienced any complications? What has been done to, you know, maybe mitigate any complications that might arise, or what has been done to help alleviate. So with diabetes complications, they're divided into two, as David mentioned before, microvascular and macrovascular. So does anyone know any of the two? Examples of any of the two? Mark, you haven't said anything. You like to attempt?
For microvascular, can you say diabetic foot?
You speak up. Can barely hear you.
Hello?
Yes.
Yes, so for microvascular, can you say diabetic foot?
You say microvascular or macrovascular?
For macro,
Macro.
yes.
Yeah, you can say diabetic foot. Would you like to also give a microvascular one or another macrovascular? Mark,
Yes. So
would
for
you like to give another macrovascular, or would you like to give a microvascular?
microvascular, I am not sure.
Okay. 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 Um, Noor, maybe you'd like to try this one. Oh, Hassan has put on the chat diabetic nephropathy. Hassan, would you say this is microvascular or macrovascular?
Micro.
Micro. Very nice. Noor, okay. Purity has also put retinopathy under microvascular. Anyone else like to try? Peripheral neuropathy. Sadia, would you say this is microvascular or macrovascular? Okay. Right. So yeah. So under microvascular, CVS disease under, yeah, very nice. So yeah, under microvascular, we have the retinopathy, we have the neuropathy, nephropathy. Then under macrovascular, we have the CVS disease, diabetic foot. And David has put something in the chat, an easy way to remember this, the pathies, microvascular. There's also another mnemonic you could use, knives. This is K for kidney, N for the neurons, I for infections. Diabetics are, more susceptible to infections, things like boils or ear infections. V for the E was what?
V was vascular.
Oh, V was vascular. So these are things like stroke, um, or like the heart disease. And then E for eyes, and then S was what? Button. Anyway. Okay, thank you guys for attempting. So yeah, so in a nutshell, the HPI, Oh yeah, it was nine. There was no S. In a nutshell, for the diabetic history, HPA more specifically, you have analysis of the symptom, you have um, important positives, important negatives, complications, risk factors. You should also have, you know, involving last sugar reading, the 24-hour diet, uh, physical activity, if any, and basic complications. Yeah. In short, by the end of it, you should have a review system and everything. Any questions? David, is there another slide or that was the last one?
There's a slide on HPI, this one, and then there's the complications and risk factors, and then the hospital progression. Yeah.
Oh.
So yeah.
Maybe someone can take us through. Almost done.
Mark, can you read? Can you read this one? Kasao Mark.
Yes.
Oh, cool. Could you read the left half?
Could you just read the whole page?
Oh, yes. There's no family history of diabetes, obesity, or hypertension. The patient
Mark,
maintains normal lipid levels. Yes.
sorry to take you back, but you haven't done the left part.
Yes.
The half on the left, he denies experiencing any blood vision. That part.
Oh, yes.
Could you also speak up?
Yes.
Could you
He
also speak up?
denies expressing any blood vision or visual disturbance, diabetic retinopathy. He denies any numbness, tingling, or pain in the extremities, neuropathy. He reports no swelling. He has not experienced claudication nor rest pain, cold extremities, and non-healing ulcers. He also denies any nausea, vomiting, abdominal pain, fruity breath, odor, or rapid deep breathing. Mouth respiration or diabetic ketoacidosis. He denies extreme thirst, dry mouth, confusion, drowsiness, generalized weakness, altered mental status, hyperosmolar, hyperglycemic state. Rule out other complication of diabetic mellitus, ignore repeated or contradictory symptoms. This is not a real patient. Patient reports no early morning facial puffness, oliguria, or bilateral lower limb swelling, diabetic nephropathy. There was no chest pain, no facial drooping, no speech abnormalities or arm weakness, cerebrovascular accident, and no history of recurrent infection. There is no family history of diabetes, obesity, or hypertension. The patient maintains normal lipid levels, has no history of gestational diabetes or polycystic ovarian syndrome, and leads a healthy lifestyle with regular physical activity and no smoking or alcohol. These are risk factors for diabetic mellitus. Then there is no history of hypertension, dyslipidemia, recent weight gain, smoking, or alcohol consumption. The risk factors for diabetic ketoacidosis, and the other one.
Thank you, Mark. Noor, maybe you could read the last one to finish it. David, next slide, please. Or you could
The
just finish this.
hospital progression. His 24-hour dietary recall includes at 9 a.m. tea with 1 spoon of sugar and 4 slices of bread. At 1 p.m. white rice with beans. At 8 p.m. white ugali, vegetables, and meat. Currently, his blood sugar level is 12.8 millimoles per liter, which is above the normal range. He's still on the bolus insulin and metformin regimen. Since admission to KNH, he has had a chest X-ray, been administered insulin, antibiotics, and analgesics.
Thank you. And that's it. Yeah, that's the end. So does anyone have any questions?
If there are none, I would like to go back to something that I was asked about the family social. Okay, but before that, I'd like to go back to this. There's a reason I placed the stable up until 3 days ago in red, while the others I was highlighting in green. So this is what I was told. This is what we were told by our consultant. The terminologies are very important. So when you say patient was last well or patient was stable, so there's a difference. There's a slight difference. So last well means that the patient had no previous incidents of disease, and they were normal until this happened. They were normal until a week ago when this happened. They were normal until 3 days ago when this happened. So stable simply means that they've been with the disease for a while. Like they've had a battle with the disease, and it's been relatively calm. Like maybe it's been managed, maybe something happened, but the disease wasn't acting up. Even though they've had it for a while, it wasn't acting up until that moment when they came to hospital. So there must be something. So the logic there is stable is for someone who's been living with a disease that has not acted up until a complication arose. So the only reason why a normally controlled disease would act up is if there's something triggering triggering the disease to occur. That's the terminology I wanted to highlight there. So when you're talking about a patient who has an illness, like someone who has had TB, and it's a chronic illness, or diabetes, which is also a chronic illness, or hypertension, you normally say patient was stable up until. And then if the patient just happened to fall down, have loss of consciousness because of a seizure, then you say, and it's very acute, like it's never happened before, then you say patient was last well this number of days ago or this number of weeks ago. That's what I wanted to share. I think you can.
David.
Yeah.
Oh, well, you're there on like seizures and unconsciousness. Common mistake that's made that I'd like you guys to avoid is put in the presenting complaint as brought in with loss of consciousness and another symptom, say vomiting. I've seen that somewhere, and it's incorrect. The thing is, when someone is brought in, actually they don't present with LOC. They're brought in. Someone unconscious won't bring themselves in. They won't walk into the ER. And then another thing is when they're unconscious, there is no other symptom. Like someone unconscious cannot experience pain. Someone unconscious not vomit, like they're unconscious. So try to avoid that as much as you can. So rather put it as patient was brought in unconscious this long ago. Then you move on. So no questions, yeah? Okay. I'd implore you guys to, maybe take a history, And then next time we meet, maybe one of you guys can present to us, so we can see progress, either resp or endocrinology history. It'll be fine.
Okay.
At least one of you.
Mm.
So you guys can just decide among yourselves who's going to take it and who's going to present. Please type it out so you could also share.
Okay. May I answer the question I was asked? There was a question. There was a question. Yeah. Grace asked me how to do a family social history of someone with diabetes. So I'm just gonna take us back right over there. Okay. So I'm gonna use an example of a 65-year-old man called Mr. Kamau. Okay. So Mr. Kamau, a 65-year-old male who lives in Limuru. Okay. I'm just gonna do a brief I'm not gonna a brief family social. So Mr. Kamau is married to his wife called Jane, and they have 3 adult children, 2 sons and a daughter, all of whom are married with children of their own. He has a family history. Okay, normally the family history of diabetes should come up in your HPI, but since I'm doing it for the first time here, I'll just say it. He has a family history of diabetes type 2, of which his maternal grandmother died too, and his mother currently is living with diabetes type 2, and his children are expressing fear of having the disease. Okay, that's on family. You have to draw a pedigree from there, as in the grandmother died, and then the mother has it, and then now he has it, and now the children are a bit worried about whether they have it or not. Moving on, his children are also concerned about their father's health and often visit to check on his well-being. Mr. Kamau's wife, Jane, has been his primary caregiver, helping him with his medication regimen, meal planning, and exercise routine. She has also been instrumental in encouraging him to attend the regular doctor's appointments and to take his condition seriously. Then, despite the challenges posed by his diabetes, Mr. Kamau remains very active in his community. He's involved in several development projects, a keen farmer, spending time tending to his farm, which provides a significant source of income for his family. Mr. Kamau's family is very close-knit. However, his condition has forced them to make some lifestyle changes, such as adopting healthier eating habits and encouraging physical activity. Something like that, something of the sort. I hope, Grace, are you still around?
Yes, I am.
Okay, something like that would work.
Okay, thank you.
Welcome.
Okay, quick reminder, you guys have HAV with Sean tomorrow. So please read up on it. Use Davidson's.
Yeah, and on another note, Savimbi said okay, I personally want to see an endocrine history from one of you. I'll send you an email that you can send it. You can pick diabetes or you can pick the thyroid issues. Okay, if that's the case, then I can have 1 diabetes case and 1 thyroid case. That would be nice. I'll just send you an email that you can send it to, and then we remark
So
on
you guys
it.
just pick among yourselves who's
Yeah.
going to take those histories, and the next time it'll be another pair of people to take the histories.
Mm.
So that's all I think.
Yeah.
We can call it tonight then.
Mm. Thank you so much, guys, for attending. Hope you guys had fun. Hoping you enjoyed, learned a bit. See you next time.
Thank you guys for coming. Bye.